are the surgeon that did the procedure for Suzanne Somers. So can you talk to us about that a little bit?
Suzanne is very generous, as you probably know, about talking about her medical issues. And she absolutely is happy for me to talk about her care because she really is an inspiration to many women and a good example of how to be proactive, which I think is one of her major lessons to us is open your mouth, pick up a book, read a book, open your mouth and be informed when you go and visit the doctor. It doesn't, good doctors like to have informed patients, like to have interested in patients. Suzanne had a lumpectomy and radiation, which is a standard treatment nowadays. Her surgery was over 10 years ago, but it's still a standard treatment for a small early breast cancer. You've got a small breast cancer. Okay, what we're going to do is we're going to go in through an incision somewhere. We're going to take a lump of breast tissue out, and then we're going to radiate the rest of your breast to protect you from any cancer cells we may have left behind. So that's a common operation now for many women with breast cancer. The problem is that the lumpectomy may be a little tiny lump or maybe a big lump. What's a lump is, in your mind. And it's most women's breasts, when you take out a certain amount of volume, if you've got a very large breast and you take out a little tiny lump, you're not going to see the difference. But if you've got a small or medium-sized breast and you take out a significant amount of tissue, you're going to see a defect, or you're going to have a volume difference. And then the radiation causes a shrinkage of the breast tissue as well and causes it to get harder and firmer. And those radiation changes persist and even worsen over the years, which is something most women aren't really fully informed about. So what happened to Suzanne after 10, 12 years, one breast is a nice full breast, and the other breast she still has, but it has a smaller volume and it's tighter and firmer, and the two don't match. And this is a very common issue after lumpectomy. The skin is still preserved, which is important, but we need more volume. And what I was able to do for Suzanne was basically an advancement of an existing operation, which is to refill that breast with fat that we've harvested through liposuction from wherever a woman has extra fat, the thighs, the hips, the love handles, and then take that fat and inject it into the breast, or some of that fat. The problem is you can only inject so much fat, and some of that fat dies, and how much of it lives is unreliable. So the idea of using stem cells, which is what I did for Suzanne, and she was really the first case in this study, was to enhance the fat that I'm putting back in by adding stem cells. They're her own stem cells. They're from her own fat, so we're not putting breast tissue back there, but we're just trying to make the fat graft that we're putting back in healthier, more regenerative, and have a better ability to survive and grow.
Can you talk about the recovery time with some of these procedures?
Sure. The recovery time from a skin-sparing or nipple-sparing mastectomy is generally very quick. It's generally quicker than a traditional mastectomy because basically the doctor, to use a common terminology, is sort of scooping out that breast tissue and then putting some type of tissue back in there, an implant or some other type of tissue in there. But the incisions are fairly small and everything is confined to the breast. So the recovery is typically very fast, and the recovery is typically more severe on an emotional level than on a physical level. For the fat grafting procedures and the stem cell enhanced fat grafting procedures, the part that's in the breast the recovery is typically very quick. A little bruising and swelling for a few days. Within 3 to 5 days, most of that is gone, and then the fat is growing and is going through its evolution of what's going to live, what's going to regenerate, what's going to be reabsorbed. But that's basically painless. The liposuction sites is another matter. Suzanne, for example, complained a lot more about the liposuction than she did the breast. And the liposuction should be a good thing in terms of improving a woman's figure. It shouldn't create deformities, but depending on how much extra fat she has, if you have a lot of extra fat, it's not going to hurt nearly as much as if you're relatively thin and we're trying to get all the little bits and pieces of extra fat. So that's not a horrible pain like a kidney stone or something, but it is sore, and you're not going to want somebody to come up and hug you in that area for, at least 3 or 4 weeks. I would say all in all, it's about a month before that sort of returns to normal and isn't very painful. Well, I think our center is one of the first because we're interested in being on the cutting edge. We're interested in providing the best care that we can that really advances women's health, and we're not locked into a large infrastructure of delivering radiation in a certain way and with a certain kind of a team. We have a little more flexibility because of that. IORT is an awkward name for something that's very simple. I explained how Suzanne had a lumpectomy and radiation, and her whole breast was radiated, so her whole breast suffered. The whole reason they're radiating the whole breast is so that any stray cancer cells are zapped. It doesn't really immunize you in the future. It just, for that moment where the radiation is going in, if you happen to have a cancer cell dividing, boom, it'll kill it. But it affects the whole breast for the rest of the woman's life. IORT is a way of doing the radiation at the time of the lumpectomy. So Suzanne had to go back and forth about 36 times to have her radiation. And she got her whole breast radiated. Whereas if you're a candidate, what we can do is do the lumpectomy, put a little radiation in right at the time of surgery while the woman is asleep. It only takes 20 minutes. There's a lot of preparation time. The radiation physicist has to be there. The radiation oncologist has to be there. There's a lot of little moving parts. But for that patient on the table, it's something that happens in just a few minutes. It's all done. And then when she wakes up, the area of concern has been radiated, not her whole breast. The amount of radiation that she gets is a lot less. Because the wound is open, we can put a little lead plate in that protects her lungs and her heart from any radiation, so there's no scatter radiation going through her to her chest where it doesn't belong. And she wakes up and Bob's your uncle, you're done.
How do you get it to be more widespread and more, so that everybody has an opportunity?
Sure. Well, that's a frustration to people like me. I can tell you it's IORT therapy has been proven in a very large-scale study in Europe. It's accepted by the FDA. The efficacy, that is the effectiveness of it, is well demonstrated. But it's not done more commonly for the same reason that a lot of things aren't done. It's easier for us to do the same thing we've always done. And especially nowadays in medicine where there are more cost pressures, there are more ingrained patterns of referral and treatment, and doctors in general are conservative and don't want to do something outside the normal paradigm. These are all factors that play a role in whether or not this treatment gets done. I think that in the future we will see this therapy commonly available, but it will be adopted slowly. Much as the same thing with the nipple and skin sparing mastectomy. The effectiveness was proven years ago, if you look at the medical literature, but it just is a matter of the end user, which is the patient, opening her mouth and saying, hey, I know there's something better. I want that. And that's what the whole history of women's breast cancer treatment has been from the time that we were doing these radical mastectomies, years ago, till the present. It's been mostly women opening their mouth and insisting on something better. And I think that right now it's the same thing with IORT treatment. Well, I'm a real consumer. I've come to I've come to actually embrace a Suzanne Somers point of view of this more than the doctor's point of view. I think that we should respect doctors. We should respect people that spend their lives dedicated to improving our health. It's absolutely necessary that as a patient that, the patient shows the doctor respect. I think we should have mutual respect, though. It should go the other way. And a patient who's informed can help the doctor a lot. It pushes our profession along to do a better job. If what we're doing, everybody is satisfied every day and nobody is saying, isn't there a better way to do this, then things will improve probably, but at a slower pace. I mean, I think we're both old enough we remember the HIV crisis. And the HIV crisis is a good example of how the public that's affected can get out there and insist on something better. And I don't think we can insist on the sun rising in the west and setting in the east. Some things we're not going to be able to change. But I do think that having an informed, interested, demanding patient population is helpful.